Welcome to the OCOM podcast, Modern Medical Education, where we gather experts to discuss various topics in modern medical education, with the focus of today's show being on OPP, OMM, OMT, and we're going to find out what all those acronyms stand for. I'm your host today, Dr. Robert Hasty, Dean and Chief Acting Officer of OCOM, and here with one of my favorite departments, and probably, I would argue, the coolest Osteopathic Manipulative Medicine department in the country, with our first guest host today, Dr. Darren McCauley, the founding chair of OMM, and also, I believe, the highest ranking physician in the Florida Air National Guard. If I got that correctly, Colonel McCauley.
That is correct, sir.
Is it Dr. Colonel or Colonel Doctor?
Colonel Doctor.
Colonel Doctor. Okay, so welcome, Dr. McCauley, or Colonel Dr. McCauley. Colonel Doctor.
Yes.
Okay. So welcome to the show. And, first of all, you founded the OMM department at OCOM. How's the first semester going?
It's going well. It is. It's going well. We brought the students up to speed with basic osteopathic history, made sure that we did everything we could to engender some osteopathic spirit, give them some pride in the profession before they even really begin to start to learn about somatic dysfunction, the diagnosis of somatic dysfunction, and the basics of OMT. Then we started off teaching them basic techniques, muscle energy, soft tissue, HVLA, and then we'll spend the rest of the year basically applying those techniques to the body, different body regions.
Awesome. Well, I'm excited to hear more about it. And that brings us to our second guest host today, Dr. April Smith-Gonzalez, founding faculty member, also in the OMM department. Welcome to the show, Dr. Smith-Gonzalez.
Thank you.
Yeah. So how are things going so far? Enjoying being at OCOM?
So far, so good. I love teaching students.
Awesome.
It's especially with the CBL focus, along with the kind of integration of OMT into all of the different topics that we teach here. That's my jam. I love it.
Awesome. Well, welcome to the show. And then our third guest host today, Dr. Sean Martin, founding faculty of OMM, and also before he came to OCOM, he was physician leadership in the WWE, and
true story.
And I understand that he has one of those big belts. I was kind of hoping he'd wear it today, the podcast. It'd be
I could have. Yeah. My ring name is Shock Doc.
Really?
No. I just made that up. But yeah, it was quite an interesting experience. Fantastic company. I really enjoyed my time with them and made a lot of great relationships. It's good to be back in education. That was the only time in my career that I wasn't actively teaching, so it's nice to be back into the educational spotlight, so to speak. It's been a great experience here, seeing us, quote unquote, go live, excuse the pun. We spent such a long time, hundreds of man hours putting together this curriculum, and now to see it in full effect is pretty awesome. I literally just walked out from an interview with a student, and he said, "So you wrote the whole curriculum from scratch?" And I said, "Well, that's kind of a misnomer. We wrote this based on the latest evolution in academics and how patients or students, learn best, but also taking lessons learned from other institutions. So we didn't just come in and just write it out of nowhere. We stood on the shoulders of giants quite literally and said, how do we make this the latest, greatest, best curriculum? So it's been good to actually see it go live with the students.
Yeah, I love that. Standing on the shoulders of giants. It's well said. Yeah.
Not WWE giants, though.
No. You really do have one of those big belts, right?
Yeah. I do, yeah.
Yeah.
Sure do. Yeah, they gave that to me as a going-away present, and they all autographed it. It's incredible. There's hundreds of signatures on it, and patients come in and I let patients just walk around with it if they want. I want people to really kind of see what it feels like and experience that. So,
are they heavy? Is it heavy?
It's incredibly heavy, yes. And it is a legit belt, a championship belt, and it is heavier than it looks, I'll tell you that.
Wow. So. And actually, I should probably point out, you're also a physician to many U.S. Olympiads, right? Yep.
Yes. We opened my sports med clinic shortly before the Tokyo Olympics, so we were pretty busy then, and then we were very busy leading to Paris. I believe we had 11 patients go, wow. And of the 11 patients, I think in grand total, there's 7 medals that have come back. So wow. It's been a great experience. Very honored to do that.
Wow. Yeah. I'll tell you, the OMM department, you guys are like the Dos Equis commercial, right? Like you're like the most interesting folks around, right? It's
yes.
Yeah. Dr. Smith-Gonzalez did not hesitate one moment with that. Right? No. I love it. Anyway, it's such a great department. And actually, we were joking around before the show, and I'll say it for the listeners, but right outside our OMM lab, so we have very prominent place. We love osteopathic manipulative medicine. It's an important part of OCOM, and we actually have this lab that's dedicated to OMM on the first floor, right when you first walk in, and right outside the lab, we have this case, and we talk about the fact that the first osteopathic medical school was founded in 1892 by the founder of the profession, A.T. Still. And, at the end of his career, he always used a cane to walk around. And so I understand when he passed away, he actually had 8 canes. All those, except for one, are in a museum up in Kirksville, Missouri. But we have the only one outside that museum from Kirksville, Missouri. It's in our case right outside of, the OMM lab. And, I joke around, and, actually Dr. McCauley and I have said this before, it seems like we have the best luck. We've had the best freaking luck ever since we got that cane. Like every light turns to green and, it just kind of works. Go out and, rub it for good luck once in a while and stuff like that. Actually, a local physician, Dr. Thomas Crow, kind of gave us a long-term loan or a permanent loan or whatever, and really grateful. He'd gotten it from his mentor, had gotten it from A.T. Still's granddaughter, if I recall. So cool.
Cane definitely has some positive energy to it.
Oh, yeah.
And I like the fact that it's right out there out front, not just as a part of OCOM itself, but also bringing, like I said, portions of that osteopathic history to the school, to the curriculum.
Yeah.
Students can feel like, hey, I'm a part of something bigger than myself, a part of a profession that's larger than where I am right now.
The other part of the lab I really love is part of the history that you made. The flag that's inside the lab that I think you flew it over Iraq on Christmas Day this past year.
I did, during a deployment in the Middle East. Still a member of OCOM faculty while I was deployed, so I wanted to give a little something back, and I was happy to fly the flag and bring it back. A lot of times a flyer, or someone who's not a flyer, I should say, will have a flag flown. They'll ask the pilot to fly the flag for them, and then the flag is flown over a given landmass, and then when the pilot brings it back, you can pick it up from him. But as a flight surgeon, I brought that flag in my own bag into the plane myself and flew it over Iraq for you guys.
That's awesome. I love it. Maybe that's what's giving us all the good luck, man. It's not the cane. It's Dr. McCauley's flag,
Maybe a little bit of both. Synergy there.
What did the pilot think of the doctor flying the airplane, though? You said you flew it?
No, I did not fly it. I did not take off or land.
Okay.
But I received flight pay from sitting next to him.
You get special pay for being on the flight?
Yeah, you get aviation pay. There's quite a few people that ask why. Like, why do flight docs get aviation pay? You're not flying the plane. You're not taking off or landing. But you still incur all the hazards of flight, the vibration, the noise. And, when someone shoots rockets at a plane, they don't let all the flight docs get out first. So you still get flight pay.
So to be clear, the flight surgeon is not flying nor doing surgery in the plane.
You can do surgery in the plane, and there have been flight docs who fly. It's actually a part of the flight medicine primary course now that you have to take off and land, but typically they don't actually let you do that in the area of responsibility.
I'm just kidding. I knew all that, but that's fine. Just teasing. That's what happens when you invite the closest department in town to come hang out at your podcast.
He's
Jab each other.
Yeah, completing each other's jokes and completing each other's sandwiches, right?
Yes.
So anyway, well, hey, we have a lot of folks listening, that may not know what osteopathic manipulative medicine is, or what osteopathic principles and philosophy, or neuromuscular medicine, or osteopathic manipulative treatments are, and stuff like that. So, OPP, OMM, OMT, and NMM, these are acronyms that we hear almost every day here at OCOM. Anybody want to try to help me out? What's the difference between all these things?
I'll take this one. So unfortunately, people oftentimes will use them interchangeably, but they're all subtly different. OPP, osteopathic principles and practices, is how an osteopathic physician thinks, right? So it's this way of looking at the body where you are trying to find health and restore health, improve the body's ability to maintain homeostasis by treating somatic dysfunction and looking primarily at the musculoskeletal system. So osteopathic principles and practices can encompass osteopathic manipulative treatment, where you are using your hands to diagnose somatic dysfunction or these perturbations in the body's soma and the musculoskeletal system, and treat them with your hands. And then osteopathic manual medicine is kind of that amalgamation of both OPP and OMT in the full practice of medicine. NMM, so neuromusculoskeletal medicine, is OMM as a specialty, and that is its own distinct field where NMM specialists receive additional training in OMM, both as an inpatient provider and outpatient provider, with some special emphasis on pediatrics and obstetrics, which are areas where the body is still developing and/or the body is changing due to the physiology of obstetrical change. So it's kind of ripe for regime change. It's really ripe for this hands-on manipulation during those two stages of body development. So OPP, OMM, OMT, all distinct, but they all work together, right, as a part of the armamentarium of the osteopathic physician. And then NMM in particular is a specialty that focuses on those three.
And recently with the ACGME merge, that has become ONMM, correct?
Yes.
Yeah.
Yes.
So
More
we added
acronyms.
we added another letter in there for that as a specialty. So osteopathic neuromuscular medicine
Love it. Love it.
is the actual specialty acronym.
Excellent. Good. So, and I will tell you, it's one of those things that I've had, just incredible, pride for, being able to have that tool in my tool belt, and, patients, love the fact that, we have these extra, skills as an osteopathic physician, that all of us get the training for as DOs. And, I'll never forget, I was in training and I was doing, a lumbar puncture, spinal tap, right? And the attending was very impressed because I was able to go in and, very, quickly, palpate, which is sort of touching, the patient, and find out exactly where it went. And, I did a perfect lumbar puncture, literally the first time actually I'd done it on a human being. And, I remember the attending physician was so impressed, "Hey, how'd you do that so perfectly the first time?" Well, it's the osteopathic training, right? That we had those hundreds of hours of extra training, to be able to diagnose and, treat patients and those type of things. So exciting about that. So good. And it's of course it's very evidence based. I mean, that's the reason why AT Still had actually started the profession, to put a more scientific and rational basis on the treatment of patients. And of course, this was the day, back in the 1800s, they were given arsenic and mercury to patients and stuff. And so he wanted to have a scientific, pathway to medicine. And he also wanted to incorporate these hands-on, techniques to take care of patients. And of course, when all the evidence came out about the hands-on, the OMM, it's very well proven right now in terms of a, proven treatment modality. Right.
Yeah.
Very much so. One of the things that I am drawn to with osteopathic history in particular is, if you really want to delve into why AT Still decided to come up with osteopathy, yes, some of that is involved in his own heartbreak by losing members of his own family to disease, but some of it is the context of medicine at the time, right? And you think about what medicine was at the time where, like you said, we were giving people heavy metals and poisons. They were bleeding patients and having bloodletting to let go of evil humors. He has a passage in his autobiography where he mentions that the treatment for dysentery at the time was to dig two holes and put the front end of the patient in one end and the bottom end of the patient in another, and just let all the fluids come out, right?
Wow.
So if that's the context of what was considered medical treatment, of course he was spurred on to actually try to find something different, The other thing that I find interesting about A.T. Still's time and about how he came up with the concepts of osteopathy is that typically we think that he developed osteopathy on his own, right? He undertook this study of anatomy and physiology, and he did dissections, and he thought about and had reflections on patients that he'd seen in the past. But when you actually delve into the history, a lot of what he did is kind of what Sean was talking about at the beginning of the podcast. He stood on the shoulders of giants. The first thing he did was look into, well, what other practices of medicine, what other ways of thinking about medicine are people involved in this time? And that was part of what spurred him on to realize that, hey, manipulation is getting a whole lot of really good results. Maybe I can figure out how to incorporate this into medical practice. But before that, I need to try to come up with a philosophy as to why I think it's working. So he kind of worked backwards to reinvent the wheel.
Mhm. One of the things I really enjoy reading about in that autobiography is his deep connection to the natural world and being able to see living anatomy in animals. And he worked on farms and things like that. So and animals in the wild, different way of life from anything we have today. But that deep connection to the natural world and how living anatomy responds and reacts and is dynamic, that piece is so important, as we approach patients and treat them.
Excellent.
Well, it's interesting because, this concept of holistic medicine is extremely popular. Everywhere you look, everybody claims to be holistic. It's on every billboard ever, I feel like now, and it's very much accepted. Patients come in and they specifically ask for a DO. They love the osteopathic tenets, and it seems like it's extremely popular now. I'd be interested to go back, 100 years when he first started the profession, how much of a trendsetter it was, how much this was a new way of thinking, a new philosophy that quite frankly, patients hadn't heard of at the time. Now it's easy to be a DO. It's extremely popular. I wonder what it was like for him when he started, though.
Mhm.
Not popular and not easy.
Not not easy.
Well, I'm glad you mentioned the word holistic, right? Which really, by the definition, means whole patient centered, right? Taking in everything about a patient, not just a disease, but all the context, the social history, the family history, the environmental considerations, those type of things about any particular patient. The only challenge about the word holistic is that a lot of people, I think, they don't understand what the word means, right? Because
Right.
sometimes they think that it's alternative medicine, but really holistic really means that whole patient-centered approach,
Yeah.
which is interesting. Actually, one of our great partners, and we love, Advent Health, but lately they've been talking about the whole patient. And I was thinking about, how osteopathic that is. I mean, that's something that you would read in anything that AT Still wrote initially about the profession, and something we've been talking about the profession since he originally founded in 1874, so 150 years, whole patient, which I am convinced that osteopathic medicine in America has really, in some ways, defined healthcare in America. Because he actually took that scientific and rational basis,
Yeah.
a leader in that, pushing the dial forward to make more evidence-based medicine. He used the word scientific rationale, but he didn't have the word evidence-based then. He, has advanced the ideas about whole patient center. Now, lots of different fields in healthcare talk about whole patient centered approach, and so I really do think that in many ways, osteopathic medicine has been leaders professionally. And part of the reason why we're probably, one of the fastest growing fields in healthcare today, right?
Yeah.
The growth in the osteopathic medical schools has about tripled, I think, in the last 20 years. I mean, it's, going up pretty quick.
What do we have, 65 schools now that are osteopathic schools?
So I believe that we're the 41st osteopathic medical school at the 66th location.
66.
And I guess there's around 230 or so medical schools in America if you count on the additional campuses or additional locations and branch campuses, both MDs and DOs. And I like to say that I think technically, if you look at it, OCOM is the newest medical school in the nation, as well as the newest medical school in Florida. So very proud of that.
Also the best.
And the best.
And
That's
also
right.
the best.
In the best OMM department.
And
right?
the best OMM department.
Yeah.
So, you think, is it the tail wagging the dog or the dog wagging the tail, right? And I think that AT Still definitely pushed the concepts of, bringing scientific reason to some of American medicine, some of frontier medicine. But at the same time, patients decided that they really wanted to be looked at as, in an entirety, right? They wanted to be evaluated in terms of their mind, body, and spirit, and not just their given complaint of the day. So I think in part, what patient desires have driven the success of osteopathic medicine, but osteopathic medicine has also driven the success of medical care in the United States at the same time.
Yeah, well said. And and there's a lot of reasons why I think that we have grown so much as a profession, right? One of the things that people don't know is that the majority of osteopathic physicians go into primary care. 57% of us go into primary care, which is a huge need. Now, of course, we're going to be graduating folks that go into neurosurgery, cardiac surgery, and they're going to be all excellent physicians, well-rounded by the time they graduate OCOM. And but a couple other things that most people know: osteopathic physicians were more likely to practice in rural and underserved areas, and we're also more likely to be first-generation physicians. Where our parents are, we're not necessarily physicians. So, so a lot of uniqueness. Of course, we love all the healthcare professionals, the PAs, nurse practitioners, MDs, everybody. But of course, I'm a little biased towards DOs. But anyway, one question I was going to ask, for this team, being the newest osteopathic manipulative medicine department in the country, what's your vision for the future for the department?
Well, my vision for the future is to be able to give students a baseline over the first 2 years, and then provide a framework where they can go out and actually practice that with preceptors their third and fourth year. So in any medical school curriculum, especially when you're thinking about OMM, you have a wide variety of preceptors, and not all of the preceptors will feel comfortable doing OMT. But if your students are empowered, and if your students are confident, they can empower preceptors to allow them to do OMT as long as the preceptors believe their confidence is well-grounded. So if we give students all the tools that they need and ensure that they practice during the first 2 years, we're not only setting them up for success during this period of time, but we're giving them the tools to ensure that they can continue to be successful during their third and fourth years when they're actually treating live patients. That's something that, it has become kind of a circle that we've gone around and around in the department in terms of how can we actually certify, or how can we guarantee that preceptors are performing OMT with students. And the one thing that we kind of it always gets distilled down to is the student has to be the one to actually say, hey, I feel comfortable doing this and I'd like to do it. Oftentimes that will get the preceptor to say, well, let me see what you got. Let's see what you're working with, right? And after the first, second, third time, now that preceptor and that student have developed a relationship where the preceptor feels confident to let the student practice.
And for me, the piece of that is there is no specialty that OMT is contraindicated for, meaning there is no specialty we can't do OMT in. And so my goal with students is helping them understand that whatever they go into, they have a superpower. They can put their hands on their patients and actually make a difference in a positive way in 30 seconds even. It doesn't have to take a long time either. So that's kind of the philosophy we're trying to instill as they go through the first couple of years, so that when they do get out there, they have a basis for what to do.
Excellent. Hey, I'll tell you, I'm feeling an increase in interest in neuromuscular medicine, osteopathic neuromuscular medicine, more now than ever. In fact, heck, I know that we have an MD that's that has sought out and is getting additional training in osteopathic manipulative medicine from your team right now, and it seems like there's a lot of interest right now.
Yeah.
Which is good, right? Because it's a evidence-based and well-proven tool and has a lot of great interest. Well, let me ask you guys, what are some innovative approaches that y'all are doing in the OCOM curriculum?
I can take this one.
Go ahead.
So it's interesting because I think the three of us, when we went to med school a couple of years ago, it was quite a bit different format. It was traditional didactic. You go into a lecture hall, perhaps some PowerPoint slides, a little demonstration. Now we'll all dismiss to the labs and we'll kind of practice on each other. And in my experience, it was a little bit more free flow. Let's just kind of practice some techniques, and then there'll be a written test and a practical. And what we're trying to do is leverage the latest technology and resources we have. One of the trends in medical education that we've seen, obviously, is this evolution of how medical education is delivered. Not everybody learns the same way. Not everybody can do well in a classroom settings. Some students can. Some students, excuse me, I keep saying patients. Some students want hands-on, some are more visual, some are more verbal, some have to write. So how do we create a dynamic curriculum that hits all those touch points in a way that maximizes the chances that all these students walk across the graduation stage as very, very well-rounded osteopathic physicians? So we're taking advantage of all the technology we can and all the learning strategies. The curriculum is extremely organized. When they come into lab, for example, they know exactly what they're going to be practicing that day. They know exactly what the expectations are. And when they leave here, they know, okay, at the conclusion of today's lab, I have now acquired the skills I need to say, yes, I can check this box. I've accomplished these objectives. I'm not just ready for this exam or practical, but I'm ready now to move on to the next stage in my osteopathic education towards becoming that well-rounded DO. So that's actually been one of the most exciting parts of working here, is the fact that the number of resources and this huge prioritization on the latest evolution in how students learn. That's been pretty awesome.
Excellent.
One of the things with our MD faculty has actually come down and looked at the lab and hung out with us in the lab a little bit. And one of the comments is that OMT is actually applied anatomy. And that is 100% true. And so they are learning in real time. You talked about your lumbar tap and your ability to find landmarks and things. That is really important, that we know how to find those things, for procedures, but not just that, for OMT applications. So that applied anatomy is important aspect of education, where it puts it into their hands, not just their brains.
Yeah, I will say, medical schools, without exception, a medical school is going to struggle in something, a topic of some sort. I can certainly name examples. But osteopathic schools, and certainly OCOM, we will have students that have incredible musculoskeletal skills. They're going to walk out of here with incredible musculoskeletal anatomy knowledge, understanding of pathology, and how to use these osteopathic concepts and tenets to treat their patients. That's guaranteed. It really is, based on this curriculum.
One of the things that I like about our approach is the use of the rubrics. It makes everything upfront. So when I went to school, and I don't know if you guys had this experience too, you learned a technique, and then you felt like, okay, I think I know this. I think I know what I'm supposed to do. And then you went to the practical and you figured out you knew it as well as you thought, or you didn't know it as well as you thought, right? Depending on the preceptor that was looking at your practical exam. But with our students, they all get a rubric. So they have a written form that gives them each and every step that is required to complete the technique. And then they have a pre-lab video where then they can actually watch it post-lab as well, so that they can watch us do the technique. So they're watching us perform the technique, and then they have a written rubric that gives them the steps for the technique, so they can constantly refer back to that. And it's not as if they just have to remember what they saw in lab and then practice that from their own mind at a later date.
Excellent. Yeah. So, one of the things that, I've always thought was interesting about osteopathic manipulative medicine education is the fact that we actually usually do it on each other, right? The students do it on another student. And of course, I think that this is one of those things that is actually really good about our profession, that, we actually have the empathy, what it's like when another person is touching us in a diagnostic or a therapeutic mechanism. And I think it, in some ways, gives you some empathy of being on the patient side of things. But I don't know, any thoughts about that?
There's pros and cons. I think that actually having students practice on each other is a way, like you said, to develop empathy, to develop some humility when someone else has to touch you, or when you need to come into lab and disrobe to a certain extent so that your visible landmarks can be seen. But I also think that there is something extremely valuable about having students, got me saying it now, students practice on patients, right? When they actually get to put their hands on somebody who has pathology, all of a sudden, all the synapses start to fire, right? Where they spent 2 years practicing on other basically young and healthy students, they're getting an experience, but that experience isn't complete until third and fourth year when they treat patients that have pathology.
Excellent. Yeah, well said. Well said. Well, what are the trends out there that you all are seeing in terms of OMM education, OMT education, OPP, OMM?
I think from a career perspective, it's popularity. We talked about this a little bit earlier. I mean, just the growth of people interested. And you see it even at the residency and fellowship level. April mentioned earlier how we've added the osteopathic to the NMM moniker. It's interesting, when I was a fourth-year med student, I was, honored to serve on the AOA board. I was the student representative that year. There's one student every year that's on the AOA board. And the hot topic that year was the joint match. That was all the controversy. And, I'm the student representative, and the students obviously were extremely opinionated. And, I was getting earfuls and giving presentations and traveling around. And, on one hand, you had the student saying, well, the osteopathic match happens before the MD match. And, for example, my number one program is an MD program, but my number 2, 3, 4, 5 are osteopathic programs, but I'm not going to go to the osteopathic match because I want to try to go after my number one, as just an example. There was all these different scenarios, and they just didn't understand why we couldn't just work together, and then you can sift accordingly based on your actual priority list. And then you had some of the more traditional folks who were afraid that we would lose our identity, that we were giving up somehow control to the allopathic profession. And obviously since then it's merged, and I think as a result, what we've seen is actually a growth of folks who are entering into osteopathic residencies. I haven't seen numbers recently, but I recall when I was a student, a lot of those osteopathic programs were going unfilled, and a lot of it was because of this phenomenon of timing of the matches. Whereas now, the residencies are filling, they're overfilling, they're having to turn people away, and you're also seeing a lot of interest in fellowships as well, including NMM. So what I see is popularity. You see growth, and going back to what we talked about earlier, now you have this almost universal acceptance from the patient base saying, well, I want a doctor who practices this way. Whether they're a DO or MD, I want somebody who thinks of my body this way. So now you have a huge acceptance of philosophy combined with this huge interest from students wanting to learn this way. So what I see is growth, popularity.
Excellent.
And I think AT still would be really pleased
Excellent.
in a lot of ways, because it's no longer quite so separate. It's just medicine. It's just another piece of medicine, good quality medicine that's being practiced.
And it's growing too, right?
Yeah.
Our knowledge base, like you mentioned the rubrics, and how we're actually using the adult scientific learning, or how adult learners learn things and stuff like that. To me, it's exciting, and of course, I've talked to some folks that are using VR with the haptic gloves. That's still kind of early phase development on some of the stuff, but to be able to use that and be able to replicate even before they go into clinical years, what that lesion feels like and things like that. So, well, anyway, one of the things I did also want to talk about is neuromuscular medicine as a career. And, as you said, that more and more people are, kind of getting into it and everything. And, I see the allures from a number of things, right? From a satisfaction as a physician, right? When folks walk out of an OMM practice, many times they actually physically feel better, right? So I'm an internist, right? And typically when and I'm, for years I've practiced as a hospitalist. I walked out of a hospital room with a patient. Well, they maybe they feel a little bit better psychologically, but they usually didn't feel too much better physically, right? And that to me, that's one of the advantages of being an NMM. And of course, I talked to some of the docs out there practicing, and it's it can be very rewarding as a career, but it's also financially rewarding, right? I know one physician was just sharing with me that they charge $500 for an initial encounter, and then I think $250 or $300 for subsequent encounters, and they spend time with patients, and you can see how it could be a financially rewarding career, but also adding tremendous value to the patient care. So what do you guys think that that's going to continue the interest in neuromuscular medicine amongst our graduating folks?
That's our ultimate goal, right? Is if we make it fun enough and we are able to light that spark in students where they want to continue to learn OMT, then part of that for a subset of them will be to say, hey, I want to specialize in this. I look back at my own medical education, and it was actually a table trainer, Dr. Gillis, if he's listening out there right now, that was the one who engendered in me the confidence to say, I want to practice this on my own. And I found that the more I practiced it, the better I got. The more other students and family wanted to come and be treated by me. And then I realized I was feeling things that I didn't think were possible to feel before. And just that kind of getting the ball rolling down the hill, all of a sudden I said, by the end of my third or fourth year, I want to do OMT. I want that to be my specialty. Now, at the time, I didn't realize that there was an NMM specialty. I thought that you just did family practice, and then once you finished doing family practice, you did OMM all day, and that's how you became an OMM specialist, right? And I figured out later, no, there's actually a residency program where you can do this and be precepted and taught by other physicians how to just do OMT. But I think that lighting that spark and having students, number one, not just treat, but really feel what they're treating, feel the diagnosis and the change in tissue, that's the beginning that will get folks to say, hey, I want to specialize and choose a career in NMM.
And like I said before, yes, specializing in ONMM is a great idea. There's a couple of tracks to do that. There's its own residency. There's a do an intern year and then it's 2-year program. There's also finish any other residency and do a 1-year program, and you can end up with an ONMM specialty. But then there's people like me that did FP-OMM and did an osteopathic family medicine residency with an OMM designation, which now I think with ACGME, they have to have that osteopathic proficiency as part of their program, and then take an extra test and get that on your residency, on your board certification. So you don't have to do all that to be a good osteopathic physician, using your hands and treating your patients.
And you're a good example of that. You're a family physician that takes care of primary care needs
Yes.
and does neuromuscular medicine, osteopathic neuromuscular medicine.
Correct.
Yeah.
Yeah.
You know, and I'll tell you, you were talking about the demand, how, when folks, see the utility, and of course, there's always stories about AT Still back in the day that there'd be like a mile long line to get
Yeah.
into his office because, he, really, and of course back then, I mean, probably tons of musculoskeletal disorders, because, fixing the farm equipment and things like
Right.
that in rural Missouri. And I'll tell you, I used to be a program director. I think most of you probably know that. I'd always have a OMT table, in the residency program. And it seemed like every year I'd always have like one resident that was pretty good at, neuromuscular medicine, osteopathic neuromuscular medicine. And then there would be like a line of residents, hey, can you take care of this back pain? Or, I've got something going on with my rib or my leg or whatever.
Yeah.
And, the demand is, I think once people appreciate the difference it can
Yeah.
make in treating musculoskeletal disorders, it's really intense. And even a lot of other non-musculoskeletal disorders, right? It's like my daughter gets headaches from once in a while, and I use the OA decompression, and the thing works, right? And of course, AT Still, I mean, what a brilliant guy! Yeah, he
Exactly.
like discovered just having the patient sit with their head over the
Hammock.
back of a
The rope.
He had
it
a
was
rope.
a rope.
Yeah, he had a
it's
rope.
incredible, right?
I'd love to know the background of that story, where he came up with that. It's pretty interesting.
Yeah.
Incredible. Yeah. So anyway,
Fascinating.
so what other things do you all want to talk about in terms of osteopathic manipulative medicine, OMM today?
I mean, I think profession, whether it's as a specialty for ONMM or osteopathic physicians in sports medicine, family practice, or in something that is not particularly thought of as a musculoskeletal specialty like internal medicine, is just continuing to grow, right? And I do think it's becoming a self-fulfilling prophecy. The more folks who perform OMT, the more it becomes part of the lexicon of medicine, the more patients seek it,
Yeah.
and that feeds back so that more students and residents go on to study it. We had a distinguished visitor here yesterday. I won't mention her name, but I thought it was, it was fascinating that we're giving her this tour of the school and talking to her about osteopathic medicine, talking to her about osteopathic medical education and OMT as an art. And she says, oh, yeah, well, my physician for the last 40 years is a DO, and now I've moved further away from him, but I still travel, through traffic to go see him because of the impression that he made on her, whether it's performing OMT or being a physician that's not necessarily doing OMT at that moment. The palpatory skills, the ability to listen to patients, the ability to display empathy and professionalism, those are parts of the osteopathic profession that we're trying to impart to our students, and it will make them a success like that doctor was, or is, I should say.
Excellent. Anything else, Dr. Smith-Gonzalez or Dr. Martin?
No, I think we covered it.
No,
Yeah.
I think we covered it all.
Yeah. Although next time we definitely need you to bring the WWE belt.
I can do that. I'll show you a few moves.
Awesome.
But touch the belt and the cane together and see if there's a lightning bolt or something.
Ooh, that might work.
I love it. So anyway, this was a great show. It was great spending time with all three of you, and really appreciate all the good work that you're doing at OCOM, and excited to see our OMM endeavors and how they'll continue to evolve, and the difference it's going to make in so many people in the future. So thank you for doing what you do, and thanks for being part of the OCOM podcast today. This has been another episode of the OCOM podcast on modern medical education.